So we start now. So everybody, could you mute your microphones? And Peter shares at the first presentation. So, hello to everybody. We are very happy that you all are here to celebrate with us the World Hearing Day, March 3rd every year. We have the World Hearing Day. At first, it started in China, and the ILP recommended it to the WHO. We had a Chinese colleague among us, and said, if we have China, we have 1/6 of the world population, which has to celebrate the World Hearing Day. But now we are happy that we are able to do it, in particular today, because today the World Report on Hearing has been launched. And some of us were able to be authors and advisors and reviewers. And this is a very, very interesting report. And I recommend those of you who were not in the first webinar absolutely to read this interesting report. But today, now, we have our session, our webinar of the Hearing Committee of the European of the Union of the European Phoniatricians. And I'm very happy to announce Peter Kummer, my dear friend and colleague, Peter Kummer. Peter is Professor of Phoniatrics and Pediatric Audiology at the University of Regensburg, where he chairs the section of Phoniatrics and Pediatric Audiology. He is also president of the German Society of Phoniatrics and Pediatric Audiology. And we are keen to hear your presentation and see it about screening for congenital cytomegalovirus infection. Peter, please.
Thank you, Katrin. I'm happy to be with you all this afternoon, and I'm happy to present about screening in cytomegalovirus infection this afternoon. Thank you. Thank you so much for inviting me to do this talk about cytomegalovirus and its association with early childhood hearing loss and how we could screen for that. An area in which we can accomplish many things in the near future to provide better help to infants with permanent childhood hearing loss, not only to provide them with hearing aids and cochlear implants, but also to avoid these situations, to cure and to moderate hearing loss, and to avoid progression to deafness. This is the reason why we should screen for cytomegalovirus infection, which is already done in parts of the world today, but not as widespread as it should be. Today, newborn hearing screening has become highly effective in early detection and intervention to permanent childhood hearing loss at birth. Most countries with high living standards have almost fully implemented universal newborn hearing screening programs, as a recent survey could demonstrate. Mostly due to screening with otoacoustic emissions or automated auditory brainstem responses, permanent hearing loss is diagnosed today at an average age of about 4 to 5 months, such that interventions can start at an average age of 7 months, with hearing aids compensating for loss of sensitivity or cochlear implants replacing cochlear function in cases of at least severe hearing loss, complemented by provision of early developmental services and later on speech-language therapy. Congenital cytomegalovirus infection, however, offers different options of therapy, a causal approach to early childhood hearing loss. In contrast to what we might be tempted to think in clinics today, congenital CMV is actually a common cause of permanent hearing loss. According to estimates like these, CMV causes 1 out of 5 cases of permanent hearing loss at birth, and even 1 out of 4 cases at 4 years of age. Thus, CMV is not only the leading non-genetic cause of deafness at birth, but also a major cause of late-onset hearing loss. And it offers to these children additional and unique interventions that may be described as a paradigm shift or a dramatic change in the way in which we treat our young patients. In addition to or instead of interventions like hearing aids and cochlear implants, the diagnosis of CCMV allows pharmacological approaches, mostly with oral valganciclovir, intended to cure or to moderate hearing loss in early childhood. For a long time, we have known a lot about hearing loss in children with congenital CMV, from studies like this from Alabama. This kind of hearing loss is not only tricky to diagnose, but also quite dangerous. This is true for both symptomatic and asymptomatic infants. In fact, only the smaller part of children that are called symptomatic will show visible symptoms. These infants may show typical signs of the infection at birth like these. For example, a blueberry muffin skin with petechia and icterus, or unspecific symptoms like growth retardation, microcephalus, or other milder manifestations of the CNS, the eyes, or even only isolated sensory neural hearing loss. The latter, and those who do not show any symptoms at all, are often called asymptomatic and comprise the vast majority. In both groups, hearing loss can be difficult to identify, since it often starts single-sided, that is unilateral, or exhibits a late onset that will be missed by newborn hearing screening. What makes it dangerous, however, is that hearing loss often shows progression, even to complete deafness. Although these characteristics have been known for some decades, a number of problems have only recently been answered and led to prominent groups, one internationally broadly based and a second based in Europe, the Dept group, to generate recommendations concerning diagnosis, therapy and screening. Diagnosis of the disease can be achieved with real-time PCR assays from dried saliva, which can be obtained and stored, and are highly sensitive within the first 3 weeks of life. This time limit is very important, since later diagnostics will not be able to differentiate from postnatal disease. Oral antiviral therapy promises benefit to about 2/3 of infants, in that it maintains normal hearing and prevents progression of hearing loss, although risks of neutropenia are widely reduced. For a well-defined group of infants, oral valganciclovir has received strong recommendations from both expert groups. And also in cases of isolated hearing loss, the Dept group strongly recommends antiviral therapy, despite lower evidence to date. Most importantly, questions of screening strategies are raised to detect the CMV disease, which is most often invisible. Epidemiological data demonstrate this need for screening. For every 1 million newborns, prevalence data from industrialized countries suggest approximately 6,000 children will be born with CCMV and may exhibit hearing loss either at birth or at late onset. Symptoms, however, will only be found in 1 out of 8 of these cases, and will be specific enough for clinical diagnosis in only 1 out of 4 cases. This is why less than 10% of the disease burden of hearing loss is currently diagnosed. What we see and may treat in the clinics today is no more than the tip of the iceberg. The vast majority, which presents with unspecific symptoms or no symptoms at all, is missed today. Half of the disease burden, however, occurs at birth and may be detected by newborn hearing screening, which is called a selective testing. Recently, a multi-center diagnostic study in the US demonstrated that about 60% of hearing loss at birth may be detected through a two-stage newborn hearing screening protocol, especially those with symptomatic disease, about 2/3, but also half of the asymptomatic infants. But will miss about 40% of the cases, mostly with mild hearing loss. It would be a comparably cheap procedure, however, with costs depending only on the referral rates of screening. Although, overall, about 1/3 of CCMV-related hearing loss could be identified. On the other hand, universal screening could close this gap and identify all infected infants, although costs would be much higher. Besides this, it would allow for follow-up of infants and early identification of those who may develop late-onset hearing loss, which comprises the second half of the disease burden, and allow a great benefit in terms of early interventions to these cases with hearing aids and cochlear implants. Recommendations for antiviral therapy, however, mostly apply to early therapy. To summarize, both groups I mentioned before strongly recommend antiviral therapy when started within the first 4 weeks of life, in cases of moderate to severe disease. Though currently controversial, antiviral therapy can also be considered in cases of isolated hearing loss or in combination with otherwise mild symptoms. Antiviral therapy for late-onset cases, however, was largely rejected by both groups. However, there are studies underway addressing this group. In summary, congenital cytomegalovirus is a striking issue because it is the most prevalent non-genetic cause of hearing loss that may comprise up to 25% of permanent childhood hearing loss overall. Additionally, there is a chance of antiviral therapy as opposed to intervention with hearing aids alone. Diagnosis with PCR from dried saliva is feasible and sensitive, can be easily taken and stored, as long as this is done within the first 3 weeks of life. Later, postnatal infection cannot be differentiated. Testing should be done at least after failed newborn hearing screening. To me, this is a necessary differential diagnostic that allows to identify more than half of the cases of CCMV-related hearing loss at birth, for which there is mostly strong recommendation for treatment with antivirals. Universal screening might close these gaps at birth and might also identify all cases of late-onset hearing loss based on closed follow-up and will allow for early intervention in these cases. Good reasons for all of us to be engaged in CMV screening. Thank you for your attention.
Yeah, thank you so much, Peter, for this comprehensive overview. And are there questions in the audience? If so, please unmute your microphone and just ask. For discussion, okay. I just wanted to show a video no, not a video, but a slide from my group. Peter and I, we are in communication about this one. This was a study we just have finished on congenital CMV screening, a universal screening done with more than 12,000 children, half from Germany, half from Qatar. And what we found is a prevalence of the infection of 0.33. Oh no, I lost my screen. 0.33, which is in the expected range. I can't see my screen. Ah, yeah, no, share. But I can't see it. Can you see my screen? Can you?
No, not at the moment. I think we left your presentation and you should restart it, maybe.
Yeah, probably. I did it. And okay. Then I need to go out. Chat, there's something in the chat. Okay, what I wanted to say is that we had 0.24% of the children who had either a late onset disease, hearing loss, and loss of vision, and some symptoms in the brain in one child, and in another child only radiological symptoms where we not know whether later symptoms develop. And these are just the targets of our screening, and yeah, gives some more reason also to discuss the kinds of screening, either a universal screening, which should be at least probatorily implemented, or a selected screening, as Peter suggested, for the failed newborn hearing screening and then retesting. However, as he told, we would lose some children. So there is a question in the chat. Yeah.
Maybe I can answer this question in the chat. The question is, for how long would you recommend the follow-up of hearing in CMV-infected children, forgetting the late onset ones? It's a good question, and I think it at least for 6 years, I would guess, is important, because as over those years, children may not tell the parents or somebody else that they are hard of hearing. It depends as well on if the child has other problems in development, and the years might be more even in those children. If the child is a symptomatic infected CMV child, maybe there could be other problems, and it depends on the developmental age, I would guess. In for normal development, I would guess about 6 years would be good enough to follow up the children. But it might be more in children who have developmental problems.
This was our recommendation as well. The Ravlison et al. Group recommended every year up to the age of 13 from year 3 on. However, I guess this is not realistic. Even after 5-6 years, parents refuse to show up with their children, because they say if something is not okay, we would probably now note it. I'm not sure. Yeah, other questions? If not, then thank you so much, Peter, for this interesting contribution. Now my own contribution follows. It is here. And I want to tell about a global survey on newborn hearing screening. I, in former times, already talked about first results, but now it's finished and the paper is published. And so I want to talk about it now. Hearing loss was the 11th most common reason for disability in 2010, but became the 4th most common reason in 2013 and 15. There is a steady increase, which we can observe. You see the graphics here, and a further increase is expected, a linear increase. So we expect in 2050 about 900 million people with a hearing loss. 7.3% of them are children. The reasons are mainly the growth and aging of the population, but we see here also that hearing loss is still an underestimated health problem in population medicine. It has still a low priority for policy makers and decision makers, and inadequate resource allocation, because it still remains the hidden disease. How did the WHO react on this situation? A new resolution on prevention of deafness and hearing loss has been launched in 2017, which calls, among others, for hearing screenings for newborns and young children, but also for elderly, and for collection of high-quality population-based data for the development of evidence-based strategies. This was the main problem so far. Nobody, or only few countries collected really data about issues like screening, hearing screening. Embedding ear and hearing care in public health systems, develop national programs for ear and hearing health, and set up multi-professional national committees for hearing health. The strategies, how to develop a screening, how to implement one, is described in the planning and monitoring brochure of the WHO situation analysis tool. Is a very useful tool to see the current status. The World Hearing Day is one tool, World Report on Hearing, of course, and the World Hearing Forum, an advocacy network which has been built up in 2019. According to WHO estimates, more than 60% of hearing loss in children could be prevented, 75% in middle and lower middle income countries, even 49% in high income regions. The differences between high and low income regions are mostly infections, among others congenital CMV infections, and shortages of programs to support maternal and child health in lower income countries. 1/3 of the preventable causes are rubella, meningitis in 19%, 4% ototoxic medication, we hear later more about it, birth complications cause about 17%. So it was really astonishing for us people from highly developed industrialized countries to see how high the proportion of hearing loss is, which still can be prevented in our countries. So for low-income countries, prevention was the most effective strategy. High-income countries, universal newborn hearing screening was the leading opportunity for fighting back childhood hearing loss. Large-scale population-based longitudinal studies gave evidence for positive long-term effects of newborn hearing screening programs on language and cognitive and academic development of children and adolescents. For example, the Australian Audiology study, a bunch of studies showed the earlier intervention starts with hearing aids, cochlear implants, the better are the long-term language and functional outcome. Or a British study from Pemberton et al. Showed that from a birth cohort of 100,000, there was a better reading comprehension of teenagers who received a newborn hearing screening compared with similar teenagers who had not. The Joint Committee on Infant Hearing, which gives recommendation in regular after periods, now recommended for those who have fulfilled already the 136 guidelines. That means screening at least at month 1, diagnostics up to the 3rd month of life, and treatment start up to the 6th month of life, to come down to a 1, 2, 3 rule. So treatment at age of 3 months, because it has been shown that it is still more effective than starting treatment at age of 6 months. This is our publication with more than 200 contributors and authors. We distributed a 19-item questionnaire to investigate the country-specific newborn and infant hearing screening status, NIHS. We asked for the proportion of babies who have been screened, for the kind of screening. That means, was it universal, was it country, state, region, institution, or at-risk baby-based screening method, autoacoustic emission, AABR, or a combination of both, the percentage of babies who would have needed audiological assessment, who failed the screening, the number of children, the prevalence of permanent childhood hearing loss, median and mean ages of treatment diagnosis and treatment start, and so on. Who does the screening? Where is it being done? And is it mandated by the government or not? So here are our results. Questionnaires returned from 158 countries. And the survey provides the first data-based information about the global status of newborn hearing screening programs, and is also included in the World Report on Hearing. During the reference period of 2009 to 2019, more than 1/3 of the world's population had no or only minimal screening, below 1%. And another third had fully or near fully implemented newborn hearing screening program of more than 85% coverage. Autoacoustic emission is the most frequently used screening method in 57% of countries, followed by two-step ORE AABR screening in 30% and AABR in 11%. The average failure rates of the screening were 4.48%, which was astonishing, but you see the range was very large. It was significantly lower in countries with high newborn hearing screening coverage, and its range was narrower, that one of the fail rate, compared to countries with lower screening coverage. The mean loss to follow-up rate of babies who failed a screening was 70.2, which is absolutely not satisfactory, but it's the reality. Here you see a map where you see the distribution worldwide of or the coverage rates of screening. The dark green is the more than 85% coverage. light green 50 to 85%, and red is less than 1% of screening, gray is no data. And you see the big difference between the African continent and North America, Europe, even Asia and Australia is, of course, better than Africa. The average age at diagnosis of childhood hearing loss of the screen children was 4.6 months, that one of non-screen children 35 months. The average age at start of intervention of screen children was 6.9 months, that one of non-screen children 35.2 months, which is a real evidence for that we come down to the sensitive periods of maturation of the auditory pathway with the screening if we detect children that early with a hearing loss. And to times when the brain structures are still physiological, well accessible for treatment. Screening is performed mostly in birthing facilities, less in outpatient clinics and homes. Although governmental mandates seem to be associated with the screening coverage, the correlation was 0.51, there are exceptions. Of the 38 high coverage countries, 9 had no mandate. So it has not to be, it's nice to have, but has not to be necessarily. Here we have the prevalence of infant hearing loss we found worldwide. It ranged from 0.3 up to 15 per 1,000 infants. 15 was in Pakistan, where the proportion of parental consanguinity is very high. Also in other countries with high parental consanguinity, we had higher rates of hearing loss. The median was 1.7 per 1,000 children. Our findings are close to a recent systematic review, meta-analysis by Busse et al., who showed a prevalence of 2.21 per 1,000 and a range from 1 to 6. Okay. The findings of the UK Millennium Cohort study was the risk of having a parent reported PCHL at the age of 11 was increased, among others, in children of Pakistani or Bangladeshi ethnicity. This figure from a former study shows how hearing loss distributes in children over regions, and interestingly, the severe or profound hearing loss is similarly distributed, but mild hearing loss has a strong range and is highest in South Asia, Sub-Saharan Africa, where also the proportion of otitis media is very high. The coverage of the screening is bimodally distributed. There's no, as I showed you. And what was very interesting is that the living standard in countries with full or near full screening is on average 10 times higher than in countries with a screening coverage of less than 10%. So the relationship between the gross domestic product and the screening parameters is interesting. It correlated negatively, of course, with the fail rate, with the prevalence of hearing loss, the mean age at diagnosis for screened and non-screened hearing impaired babies, and the mean age at treatment start for the screened and non-screened babies. So rich countries should do much more for less wealthy countries to support them. That's what I told you. Low-income countries, you see them here, had hardly any screening, but from the high-income countries, there was a relatively large variance in GDP because it included countries with central government, such as in Belarus, China, Kazakhstan, Micronesia, Russia, which was less wealthy, but mandated the screening, and so they got it. The lack of regional or national NIHS databases and regular data collection impacts the quality of many screening programs. Such a lack is associated with a dearth of tracking programs to refer babies who have failed the screening to audiological diagnostic and treatment services. Without tracking, the loss to follow-up rate is usually high or simply unknown. It means in countries with fully functioning screening programs, the loss to follow-up rate was on average 7% lower than in countries with lower coverage. Okay, there are many programs with institution-based hearing screenings in Arab, Southeast Asian, Latin American countries, but no information about relevant screening parameters are available there due to the lack of data. Okay, the growing prevalence of hearing loss calls for action, including the implementation of newborn hearing screening programs and to improve the just existing programs. This should be a part of national programs for ear and hearing care. Regular standardized data collection is necessary to improve the program effectiveness. The screening and follow-up treatment have been shown to be an excellent investment of resources. So resource allocation for these programs is needed. That means also for screening centers for tracking of babies and program monitoring. Governmental mandates and guidance is needed, but not absolutely necessary. Clear definition of the target parameters, the presence of tracking systems with bidirectional data transfer from the screening devices to screening centers and back, the accessibility of pediatric audiological services and rehabilitation programs, and use of telemedicine where connectivity is available, which is nearly everywhere in the world now. The opportunity for case discussions in professional excellence circles with boards of experts is often necessary and not done. These are some of my conclusions, and I thank you so much for your kind attention. Okay, are there some questions? I don't see questions. No questions. Okay. In this case, I would like to announce my colleague, our colleague, Jakub Strata from the Charles University in Hradec Králové in the Czech Republic. And I'm very happy that he is able to present here because he was sick some weeks ago, I guess, Jakub, by COVID-19 infection. So all the best for you.
Oh, hello, good afternoon. Can you hear me?
Yeah.
Thank you very much for inviting me to this webinar. I would like to ask you for the first slide in order to share with you our experience from Czech Republic about the role of hearing aids and implantable devices in pedaudiology. Please, Katrin, may I ask you for the first slide? Well, I hope I have managed to share my presentation. Do you hear me, please? Thank you very much. So once more, let me share our experience from Czech Republic about the role of hearing aids and implantable devices in audiology. So the current technological possibilities in medicine have reached so excellent level that hearing improvement can be provided for virtually every time and severity of hearing loss, from minimal hearing impairment to complete deafness. Modern hearing aids, including implantable devices, together with other assistive listening tools, are able to improve hearing and comprehension in common listening situations, as well as in until recently hardly solvable situations, such as central hearing loss or unilateral deafness and similarly. At the same time, it must be considered that hearing is a basic precondition for development of speech and thus also for education and social deployment. So the challenge of today's phoniatrics, therefore, is primarily to capture the needy patients with hearing impairment and to offer them adequate hearing correction. The most powerful program for detection and hearing impairment of newborns is a newborn hearing screening system, universal NHS, respectively programs of early hearing detection and intervention. This is what we could hear in the previous lecture by Professor Neumann. There are many countries in Europe with different health systems and economic levels, and at the time being, several working groups of various European health organizations have been working on newborn hearing screening and its implications. In 2019, for example, an U-Screen project founded by the European Union was set up to analyze existing European neonatal hearing and also vision screening programs. And the aim of the project is to compare the screening systems of individual countries, including some non-European states, and to recommend optimal procedures with regard to the individual healthcare systems and economic possibilities. We could already hear from Professor Neumann how various are possibilities of various states within our globe, within our Earth. Another group is EFAS working group, the group of European Federation of Audiological Societies, which, for example, has been working on transnational tests for hearing screening. And our working committee, our hearing committee of the Union of the European Phoniatricians under the leadership of Professor Neumann deals with hearing from the point of view of phoniatrics. It means especially the communication aspect of hearing. In the Czech Republic, the newborn hearing screening has been developing since the 19th of the last century, but it was not until 2018 that a network of regional coordinators of nationwide screening was established. Our national goal is firstly to determine the hearing status of all newborns, then to ensure the rehabilitation of hearing and speech for all those in need, and finally to achieve a quality of care comparable to developed European countries. The methodology unification of our screening and data transmission has been petrified in legal standards. The promoter of this work was especially Professor Chrobok and his group. Updating the company's ENT website, the results are regularly published in professional journals. This way, we can make the acknowledgement about hearing screening among the professionals in Czech Republic. Our experience with the data management, which is performed here in Hradec Králové, has become an expert basis for an emerging national register, the launch of which is being prepared for the beginning of 2022, provided there will be made the necessary legal material. The data management is then to be performed by the Czech Institute of Health Information and Statistics. This way, the functioning of hearing screening in our state will be ensured at a state institutional level. And this is what I think very important, that the hearing screen program is supported by the state. So what is the current role of hearing aids and implantable devices in pedaudiology? The advances in the performance of hearing devices follow computer and communication technologies like mobile phones and similarly. The availability of these technologies is practically barrier-free in most European countries. The hearing devices make it possible to correct hearing impairment of practically any kind, both distal and central location of the auditory system, bilateral, unilateral, from minimal hearing loss to complete deafness. Thus, the main challenge of today is not the technological, medicinal, or economical limit, but the timelines. And this also corresponds with the previous lecture of Professor Neumann. Hearing is namely the basic prerequisite for speech development, so children in need of hearing correction must be captured in time in the pre-speech period. There are several rules used, as for example the ID rule of 136, as Professor Neumann has already said. In Czech Republic, we apply a rule of 3. It means screening by the 3rd day. Rescreening, it means once more screening at ENT workplaces by the 3rd week. Diagnosis making and hearing correction by the 3rd month, and possibly a cochlear implantation, when needed, of course, within 3 years by the latest. The cochlear implantation is mostly indicated in children with severe and profound hearing loss. This is the gold standard. Thanks to the newborn screening system, the age limit for implanted children has recently fallen to the 6 months of age in many countries. The main trends in current implantology are now, among others, cochlear preservation, pre-implantation, cochlear modeling, and robotic implantation, lowering of the age of the implanted children, lowering the hearing threshold for implantation, implantation of children with disabilities, and of course, advances in device technology, hybrid and bimodal stimulation, wireless transmission of listening data, etc. In Czech Republic, which has about 10 million people, the hearing screening system enabled the expansion of implant centers to the current 5 workplaces. There are 2 in Prague, one for adults, the other for children. Another implant center is in Brno, another in Ostrava in North Moravia, and one in our University Hospital, Hradec Králové. The age of cochlear implantation has dropped to 12 months. In most European countries, the technological, medical, and economic limits are not the main problem with hearing corrective devices. In Pädaudiology, the hearing correction is associated with other issues. This is the uncertainty of hearing threshold due to the young age of the captured children, newborns, problem of maturation of hearing and further hearing development. This corresponds also with the lecture of Professor Kummer. Let's mention the Cytomegalovirus infections. Handicaps that hinder verification of hearing threshold by psychoacoustic methods like visual reinforced audiometry and similar. This is then a big challenge for a correct setting of the hearing aids for their amplification, respectively setting of speech maps of the cochlear implants. The problem of definitive loss of hearing by cochlear implantation can be overcome by new tiny electrode arrays, electroacoustic stimulation, sequential implantation. These all are options that fit the hearing correction to individual needs. Yet, 6 months seem to be currently the age limit for cochlear implantation, among others for anesthesiological and blood loss risk, and last but not least, the temporal bone thickness. So, in conclusion, we can certainly agree the hearing aids and implantable devices have made tremendous progress in the last decade compared to, for example, surgical techniques or surgical skills. However, the sophistication of hearing aids is not crucial for the success of hearing correction. The key is the timely detection, timely diagnosis, and timely correction of hearing impairment. A hearing correction is to be provided in time for every child in need. This only can prevent from becoming deaf and deaf-mute. Ideally, the hearing correction should give the hearing impaired child life chances comparative to his or her healthy peers. Thank you very much for your consideration.
Thank you so much, Jakub. Very interesting. Are there questions from the audience? Some questions from the audience. I wonder if you, I know the newborn hearing screening program in Czech Republic, and it's really advantageous. It is modern and has a good outcome. I wonder about the time gap between your 3-3-3 rule, which is very nice, and the long period until cochlear implants are done, because for a long time, cochlear implantation in children starts at age 6 months. Could you explain that?
Thank you for the question. Yes, we are speaking now about a rule of 3, and this is what we try to implement to each workplace in Czech Republic, to all maternity units, to all ENT workplaces that are involved in the screening program. But still, the program, this newborn screening program, is in progress, in process. So, of course, we cannot change the timing of cochlear implantation. Everything takes time. We observe a dropping of the age in which we implant children. Now it's lower than some years ago, but it is still our goal that is in front of us. So the explanation is quite simple. We are still in progress.
Okay, more questions? If not, then again, thank you so much, Jakub. And we give the floor to Antoinette Amtsenov-Dinesen. Professor Amtsenov-Dinesen was my predecessor here in this clinic. She was the director of the Clinic for Phoniatrics and Pediatric Audiology at the University of Münster. Furthermore, she's past, was former president of the German Society of Phoniatrics and Pediatric Audiology, and she was president of the Union of the European Phoniatricians, and awaked this organization to new life. We are very thankful for that, Antoinette, and we are keen to listen to your presentation. Please.
Thank you so much, Katrin. I'm highly honored to be allowed to participate in this WHO webinar. I'm very happy. and ototoxicity is my topic, and that is cochleotoxicity. So this structure is heard, and it's also vestibulotoxicity, so it's poisoning the equilibrium organ. And cochleotoxicity means hearing loss and tinnitus, but data are existing only on hearing loss, and I have to limit my lecture to the platinum compounds, cisplatin and carboplatin. Cisplatin is a highly effective chemotherapeutic agent in pediatric oncology, and its use is limited by side effects such as ototoxicity, neurotoxicity, nephrotoxicity, and myelosuppression. And here you see the cochlea. It's like a snail with 2.5 turns. And there are some ducts, and the most important duct is this cochlear duct. And within this duct, here are the hair cells. These are the sensory cells of the ear system. And cisplatin, as a side effect, generates toxic levels of reactive oxygen species, that is ROS, and this induces apoptosis, that means a cell death program. And the first victims of this are the outer hair cells in the base of the cochlea. And here you see the degeneration of outer hair cells before and after ototoxic damage, shown here in these figures in an animal experiment. So here before and here after ototoxic damage. As the first victims are the hair cells in the base of the cochlea, primarily cisplatin-induced hearing loss manifests with a bilateral sensory neural hearing impairment, beginning in the high frequencies. This is the scale for the frequencies, here for the loudness, and here you see a typical high frequency hearing loss. And this causes difficulty in distinguishing high frequency consonants, which are important for speech intelligibility, and reduced music perception and reduced perception of ambient noises. If the hearing impairment progresses to more speech-relevant frequencies and a higher degree, like in these examples, sincere consequences for a young child's language, psychosocial, emotional, and academic development may result. Some people think that, oh, high frequency hearing loss, it's not so important, but it's problematic in noise, especially in noise. And in this example, you see a severe case of high frequency hearing loss. Red is the right ear and blue is the left ear. And if you add a noise, 60 dB loud, so you see that the speech discrimination is dramatically reduced. And this is really a problem, especially for children at school. They have a greater listening fatigue resulting from the increase in listening effort, a reduced attention span, a poorer school performance, and quality of life is reduced. So if we have a look into the literature concerning the clinical incidence of cisplatin-related hearing loss in childhood, so this ranges from 1.7 to 90.5%. Why? Sometimes there is a low number of cases in the studies. Then we have heterogeneous study populations and study protocols. And a big problem is that there are different definitions of hearing loss and different audiological classifications and different time points of audiological measurement. For example, during chemotherapy or at the end of chemotherapy, or monitoring progressive hearing loss in post-therapeutic follow-up protocols. Risk factors are a pre-existing hearing impairment, very young age of children, high cumulative dose, cranial irradiation, surgery involving ear, auditory nerve, or a combination of cisplatin with carboplatin or other ototoxic medication like aminoglycosides or loop diuretics. In the following, a selection of studies performed by the Münster team and cooperation partners is presented, and we have nothing to declare for these studies. We could, for example, show that short-time infusion is a risk factor. We could also show that co-medication with furosemide is a risk factor. And we could show that combined radiotherapy technique, that means you give a cranial irradiation and in addition a dose boost, that this is combined with a higher risk of hearing loss than tomotherapy. That means you do radiation combined with a computer tomograph scanner, and this is much more exact, and surrounding tissue is preserved. We have observed, and also others in the literature, that platinum tolerance is interindividually different, and we assume genetic variance. And important is the influx, and important is the detoxification concerning these inner ear structures. And we could show that a variant of glutathione S transferase plays a role in the detoxification process. And concerning the influx, we could show that the megalin receptor and the organic cation transporter 2 play a role. And this is very interesting because this offers targets for therapeutic strategies. Then we performed a lot of studies within the PenCare Life EU project on audiological data from child and adolescent cancer survivors, gathered as part of the Work Package 5 ototoxicity of this initiative. Münster has been the audiological reference center for 17 institutions in Austria, Czech Republic, Denmark, Germany, Italy, the Netherlands, and in Switzerland. And this is our PenCare consortium. We could work on 10,320 audiograms from 2,696 patients, 50% male, and most common diagnoses were bone, brain, and liver tumor, tissue sarcoma, and neuroblastoma. We have developed a special audiological classification system for high-frequency hearing loss, the Münster classification, with multi-level discrimination within the hearing loss categories and considering tinnitus and minimal hearing losses. And we could show that clinical relevant hearing loss was present in 48% of the children. And here you see that special risks are an age under 5 years, cranial irradiation, and a platinum dose from more than 450 milligram per square meter. And we found out that an age under 5 years means a 3.9-fold risk, that a dose from more than 450 milligram per square meter means a 5.0-fold risk, and cranial irradiation means a 3.53-fold risk. We could perform studies on 900 patients with a genetic analysis on 14 variants in 11 candidate genes. And we found out that a special variant in the ACIP2 gene and also a special variant in the SLC22A2 gene were associated with ototoxicity. The ACIP2 gene with the gene locus 6q25.3 hints to muscle metabolism, and the SLC22A2 gene, gene locus 2p16.2, is an organic cation transporter gene, which is important for detoxification. But the evidence is not yet sufficient to recommend specific screening markers, and we assume a polygenic model. So as progression of cisplatin-induced hearing loss is possible during treatment after end of chemotherapy and more distinct in combination with cranial irradiation, it's very important to do audiological monitoring. And we need a standardization of surveillance modality, of classification systems, of time points and audiological tests to generate comparable monitoring data. And we were allowed to work with the International Late Effects of Childhood Cancer Guideline Harmonization Group, and we could develop recommendations which are published in Lancet Oncology. This is the International Guideline Harmonization Group for Late Effects of Childhood Cancer. At present, we are updating the German guideline on long-term follow-up care of children, adolescents, and young adults with cancer disease. And now I want to talk a little bit about carboplatin. In pediatric tumors, it's used for retinoblastoma, osteosarcoma, and neuroblastoma. And one of the side effects is ototoxicity. The clinical incidence of ototoxicity of carboplatin associated hearing loss ranges from 7 to 46%. And we know that there is a higher incidence of hearing loss related to young age, combination with cisplatin or cranial irradiation or other ototoxic drugs, a higher dose of carboplatin, and osmotic opening of the blood-brain barrier. The last thing I want to address is otoprotection. There is a multitude of drugs which has been tested to identify effective otoprotection under platinum therapy. And related to the pathomechanism that ROS lead to cell death, antioxidants are promising, especially sodium thiosulfate, STS. In patients with hepatoblastoma, STS was applied by infusion in a multi-center randomized phase 3 clinical trial with 48% reduction of incidence of hearing loss without affecting survival rates. Another approach is to link STS to a hydrogel, and this gel is administered intratympanically, and then the STS can release from this gel through the round window into the cochlea to protect the hair cells against the ototoxic effect of platinum drugs. but the studies are ongoing to avoid conductive hearing loss as a side effect. So there are still to-dos to develop monitoring standards, to clarify the pathogenetic basis of ototoxicity of platinum compounds, to stratify clinical risk factors, to develop pharmacogenomic markers, to identify high-risk patients very early, and to develop otoprotective strategies without reducing efficacy of tumor therapy. And I'm very grateful to the teams from Professor Marie van den Heuvel-Elbrink from Utrecht and from Professor Thorsten Langer from Lübeck and Professor Oliver Zolk from Rüdersdorf, and in Münster to the Münster team and Professor Charimbuli, Docent Skobiala, and Dr. Landfors-Kaminski, and I'm very grateful for your attention.
And we are very grateful for this wonderful presentation and comprehensive and up-to-date presentation from first hand. Are there questions in the audience? Questions? Please ask your questions. I have a question, Antoinette. How long do we expect platin effects? How long do we have to track the children who got cisplatin?
Yes, this is really a very, very good question. We think that monitoring has to start after end of chemotherapy, and then every half year, at least in the first 2 years. And then it would be very good to continue at least once a year in the next 3 years. But there are special groups of children who are at a very high risk. So, for example, children who have also got cranial irradiation, they should be even monitored longer.
3 years, this is really astonishing. The same question came from Bettina Schickinger-Fischer. Pardon, I haven't seen that, Bettina, but it's exactly the same question. Can you say something about carboplat, about how long to follow through, or don't we know that so far?
Yes, carboplatin is not so ototoxic as cisplatin, but under special conditions, it's also very ototoxic. So if you give a very high dose of carboplatin, or if it is combined with cisplatin or cranial irradiation, or if you open the blood-brain barrier, it's really also very ototoxic. And I would also recommend a longer time interval for monitoring. I think at least 2 years, but we do not know at this time point very much about carboplatin ototoxicity. There is still much scientific work to do.
And I'm very glad that this will be our next common study. Yoo-hoo! So it's so necessary and so important. I thank you so much, Antoinette. Borut, hello Borut from Croatia. I'm happy that you are here. Borut asked whether you can get the recordings. Hello. Yeah, hello, Borut. Yes, we recorded all the presentations, also from the webinar before, from the ILP, and also the next from the German Society of Audiology will be recorded, and from the last from the German Society of Phoniatrics and Pediatric Audiology. And we will send around a link where you can see and watch again the presentations. So,
thank you so much.
I thank you, and I thank you all for your nice attention. I hope it was interesting for you, and I still wish you a good and interesting World Hearing Day. For those who remain in the Zoom room, we proceed at 5 o'clock with the next webinar. Okay, have a good time.